I'm Elizabeth. I'm a named GP for Safeguarding Adults. I started doing safeguarding about 10 years ago, and this topic was something that right from the beginning of my work I couldn't quite understand what was not happening, I think is the correct way to put this really. So I'm going to just really talk you through about the service that we're running as what's now called a prototype forensic service for adults at risk of harm in the Humber region. At the moment we're just running it in East Riding and North Lincolnshire because that's where I'm based, but we are just in the process of now rolling it out to the whole of the ICB, so it's hopefully exciting times. So just a quick plug, I know it's Safeguarding Adults Week, so I'm a trustee of the Ancraft Trust, and it's really the Ancraft Trust who introduced the whole concept of Safeguarding Adults Week. So I'm sure most of you know what the Ancraft Trust does, but it's an independent charity supporting adult safeguarding, and they do some amazing stuff. I mean, I got sort of coerced into being a trustee by a friend of mine who was already a trustee, but it provides training. It'll come out to organisations and do audits. They deal with everybody from farmers to theatres to lots of sport, and they do some really good work. They'll provide mentoring, they'll provide supervision. So, for small organisations, not like the council, who obviously have all their systems in place, but there are small organisations that don't have the expertise they need, and Ancraft Trust will support them. And they do lots with learning disability, which is really where they started out from. So as I say, if you don't know about them, have a look at their website. But as I say, I'm sure, given your occupation, you probably do. So, how big's the issue of physical abuse? Well, it's the second most common reason for there being a Section 42 in England. So if we look, there's about 160,000 Section 42s undertaken in England each year. These are statistics from 2022 to 2023 taken from NHS Digital. So the biggest category is neglect and acts of omission, which won't surprise you. But then the second biggest category after that is physical abuse. So it's obviously a really important, type of abuse that we should try and know as much about as we can and deal with in the best way that is possible. So, it is a significant issue, and I think it's an issue that probably we haven't dealt with really as well as we could have done. I think when you actually start looking, because as I say, I became interested in the whole concept of physical abuse, and when you start looking into sort of the research literature around physical abuse, and particularly in England, you get quite a lot of stuff that's from America, but that's all about elder abuse, and there's a little bit from other countries, particularly Australia and some of the European countries, but there's very little known. There's virtually no studies about physical abuse that have been carried out in the UK. And I think we must be really clear, and Mark Lax is a professor at one of the hospital medical schools in America, and it's really clear. He's done some really good studies looking at the effect of that abuse has on adults. As I say, his work is all around elder abuse because that's what they have in America. And basically, if you are the victim of abuse, the abuse may not kill you, but it certainly increases your what we call all-cause mortality. So that means your risk of dying within the next year probably doubles or even trebles. And I think, just from experience, when I've been involved in Section 42s, you're quite often doing the Section 42 and then the older person will die a relatively short time later, and the cause of death will go down as pneumonia or various other things. But when you look back, they've had that significant impact of that abuse, and without a shadow of a doubt it affects their health and affects their mortality. So I think we do need to take physical abuse really seriously. So these slides might be a bit confusing. So if we just start off with this graph chart on the left. And the figures that really matter are the figures in brackets. Just ignore the figures that are not in brackets. So the people who are the victims is the column here on the left, and the people who are what he calls the controls are the column on the right. And what the chart on the left shows is basically the frailer you are, the more pre-existing conditions you are, the more likely you are to be physically abused. And I think, looking certainly at the data that we've got from the Humber region, that fits in with who we see. And then the chart on the right shows that if you've either got depression or dementia, that again you are much more likely to suffer from abuse or neglect. And as I say, I think that fits with what we see when we're doing Section 42s. So the history of the project really, I'd always been aware that we didn't really have anything for adults who'd suffered an injury. There was nothing, there was nobody to interpret the injury, nobody to document the injury. And obviously for children, we have a service that runs really slickly and has run for many, many years. So we had a really significant SAR in North Lincolnshire, and it's available on the website, and it's called Adult A. And after having been taken part in, I collected the data from primary care for the SAR, and it really struck home with me. And I think that the thing that really struck me, so we had our terms of reference questions that I went out to primary care with, and I interviewed everybody in the practice who'd seen this gentleman, but this gentleman had suffered really significant bruising. I mean, it was really significant, all on his torso, included his genitals, and he had other bruising elsewhere as well. The ACP, so that's an advanced care practitioner, and they quite often do the care visits from primary care to care homes. I just said to the ACP, who was a really thoughtful young man and was very experienced, and so I said, well, so what did Adult A look like when you saw him? And he just looked at me and thought for a minute, and he said, he looked like he'd been in a car crash. And that really struck home with me, that here was a gentleman who, similarly to what we were saying about the increased mortality, he didn't die of his injuries, but he did die about 6 weeks after he'd sustained those injuries, taken into hospital, didn't go back to the same care home, and he did die. So as I say, my aim was to stop this terrible inequality between children's and adult services, and see if we could trial a service for adults that then other areas could either copy. And I mean, obviously, my sort of dream would be if the departments of health would decide that this was a good thing, because the children's services is centrally commissioned and the money comes centrally. And why don't adults get that money for a service? I think it's wrong. So we provide a documentation service. So what that means is that I will go out and document the injuries. I don't always go out. Sometimes I work from photographs. And I'll then write a report, and then I will hopefully, if I can, interpret those injuries to say whether I think they're non-accidental, how they might have happened. So the whole essence of this project was to establish sort of what was called proof of concept, that this could work, because the children's service you couldn't just mirror for our adults, because adults are different from children. So as I say, we had to so as I say, that was basically where we came from and what we hope to achieve. So this is Adult A. This is actually Adult A. I have worked with his family because his family, needless to say, were hugely upset about what had happened to him, and they felt that the investigation wasn't thorough enough into what had actually happened to him. So I'll just tell you a bit about Adult A. So Adult A, as I say, I have kept in touch with his family. I had nothing to do with his family at the time of the SAR. His family weren't entirely happy with the outcome from the SAR, which I don't think is that unusual when your loved one has really, really suffered. could. But he was an amazing man. He was mayor, as you can see. He did lots of charity work. The family are involved in a local business, so they're quite a well-known family locally. And as I say, there are two reasons that I've kept in touch with them. One of the reasons was that I use his SAR all the time, and I would be really mortified if word got back to them that I was using the SAR and I hadn't told them. And I also wanted them to know that although they were happy with the outcome of the SAR, that we were trying really hard to get this service off the ground, which hopefully, if it had been around at the time when he'd been injured, we maybe would have had a better response. So as I say, so he was an elderly man. He had dementia, which was well documented. He lived at home with his elderly wife, and his elderly wife was doing her best to provide all the care she could. He did have two daughters locally, but they were a farming family, and it was coming up to harvest, and they were really concerned. He was wandering at night a little bit. They were concerned for the mum. Harvest is a really busy time for any family who has a farm. The daughters were concerned that they weren't going to be able to provide as much support as normal, and so he went into a local care home. He was self-funding, so I think that was a bit of a problem in the sense that he was self-funding, and they'd got power of attorney for health and welfare and property and affairs, which meant that they basically chose the care home themselves. And they chose it for really good reasons, in the sense that it was really local. The mum, the wife, who was probably 86, I think, at the time, could get there by herself, and it was part of the community as well. So they chose it for really good reasons, but given his dementia, it might not have been the best place, but that is just one of those things. And as I say, he was only in the care home for about 2 weeks, and over that period of time he'd sustained all these injuries. So as well as the ACP feeling that he looked like he'd been in a car crash, when he was admitted through A&E, the doctor wrote down there that the injuries, because they were put down by the care home to falls, so the hospital felt the injuries were out of keeping. But when push came to shove, and the doctor was asked to do a report in A&E, he sort of got scared and wouldn't do it. And I think I do understand that, but it didn't really help. So I'm sure you've seen a quick picture of adults. So this is me. Oh, that's really interesting. So this is me at the end of the SAR, and I really, really, really felt like this. I mean, I just thought the SAR, and I'm sorry because I know you're counsel, I know you probably do your terms of reference and all these things, but the bruising was never considered in the terms of reference for the SAR, and I understand that because it was too difficult, really. And I don't know, that was my perception. It was too difficult, and people didn't want to go there. And in all fairness, I've moved slide and it seems to have recovered. But anyway, so I just felt that we hadn't done justice for this gentleman, and I literally did lay with my head on my hands at the end of the SAR for various reasons. But the trouble was, it then gave me the bug. I felt this is wrong, and as I was laying with my head on my hands, I said to my boss, I just don't feel very good about any of this. And she said, well, if you don't feel very good about any of it, what are you going to do then? So that was what really gave me the bug. It was having seen the photographs of this gentleman, listened to the people who said how awful his injuries were, and as I say, that was what made me feel that we had to do something about it. So as I say, we've got this discriminatory gap between adults and children. I mean, I think it's just wrong. I think legally it's wrong because, the Equality Act is really clear that you can't discriminate on the grounds of age in terms of providing a public service. So, I mean, I think we've even got legal grounds. I mean, there's moral grounds and ethical grounds, but I think we've also got legal grounds as well. I do think it's a big task. I think it's actually a bigger task than with children, for all sorts of different complex reasons. I mean, one of them is I go out to see people, whereas the paediatricians always bring children into the hospital. But a lot of the adults I see, you can't just pick up and take to a hospital. It would really distress them. So if you've got somebody who's neurodiverse or somebody who's got really severe dementia, it would just upset and confuse them even more to move them from their environment. So So, you know, it is a problematic service, and so I think it does need a slightly different approach, but I still think, you know, we're in a situation that is not right. So just to tell you, and I think, because I assume that most of you are social workers and not from a health background. Yeah. So forensic medicine, and when I say forensic medicine, I'm not talking about real specialist doctors that you see on Silent Witness. I'm just talking about forensic medicine in general, is not taught at all in the undergraduate curriculum. So in medical schools in the UK, no forensic medicine is taught. Interestingly, when I qualified, we did do this tiny sort of little block, but it was literally a couple of days, but it's not taught at all now. So that means that no doctor coming out of medical school will really have any idea. And I mean, I've been a GP for sort of 30 odd years now, and in all my postgraduate curriculum I haven't been taught any forensic medicine either. And I think what that means is that nobody you know, has the skills. So when the doctor in A&E wouldn't write a report for adult A, I don't think that was right morally, but I could understand where they were coming from, because if you're not being trained to do something, you probably shouldn't really be doing it. So as I say, forensic medicine isn't taught in either the undergraduate curriculum or the postgraduate curriculum. So we're not off to a very good start in terms of being able to look at adults and talk about injuries. And certainly you know, when I've done my children's safeguarding training, the paediatrician will come along and talk about injuries in children, but I'd never heard anybody talk about injuries in adults of risk of harm in the sort of 10 years that I'd been doing adult safeguarding. So what we did, so we were in a chicken and an egg situation really. What did we do first? Where did we go? How were we going to even start to make any inroad whatsoever into this problem? And what we did, because I've had amazing support, we've got really good teams, you know, we work really closely with our council. What we did was we just had a sort of workshop focus group where we got everybody around the table. So we had the police, we had health from what were then CCGs, we had the adult social care, we had board support and help, which was really, really helpful. And we literally just sat for a morning, and we had some presentations. We had a quick presentation from the police, I did a quick presentation about the SAR, and then we literally just tried to brainstorm what the issues were, and everything was recorded. So we then came away with everybody's groups, everybody broke into groups and sort of brainstormed what the problems were. And I felt really that we needed to start with education, because none of us can do anything if we're not trained to do it. So but I didn't know anything, you know, so I couldn't provide anybody with education. So I just got on, you know, started Googling, and that's one of the marvellous things about life now. So I just started Googling, and I came across the Faculty of Forensic and Legal Medicine, which I'd never heard of prior to, as I say, getting into all of this. So just, you know, me being me, I saw the generic inbox for their emails. So I thought, I'll email them, because I looked at their website, and so they have, so the Faculty of Forensic and Legal Medicine, they're the sort of professional body that set standards for forensic physicians. So we have forensic physicians who do the SARC medicals, so Sexual Assault Referral Centre medicals. We have forensic physicians who are in custody and look after detainees, so people who may have committed a crime, and they also quite often deal with like the road traffic stuff as well, in terms of, you know, breathalyzing, drug testing, you know, all that kind of stuff. And then they have the children's safeguarding on their website. They had no adults safeguarding on their website. So I emailed them and said, you know, a bit funny. Can you tell me, you know, you've got children's safeguarding, you've got all the rest of this stuff, but I've got no adult safeguarding, and we're trying to set up this project, and, you know, what do you think you can do, type thing. So, I mean, I was very lucky. So the president at that time was a lady called Margaret Stark, Professor Margaret Stark, and she got back to me and said, oh, you know, maybe we should have a chat about this. And they've been absolutely, you know, instrumental in helping us with this. We put together a course we worked out what skills we thought people needed. So they needed to learn to document injuries, write a report, interpret the results. So we put together a course, and we involved the police, we involved adult social care, and put together a 2 half days. So it's a full day split into 2 half days with some sort of homework in the middle, and it's designed for healthcare professionals so that they can start doing this work. So we designed a course. I personally, as sort of clinical lead for this, felt a bit sort of that I needed to be a bit less exposed. So at Teesside University you can do a master's in forensic medicine, so I didn't do it all. I just did the bits that were actually pertinent to what I was doing. We've raised awareness in primary care, because basically there's no point having a little group of people to examine people with injuries that may be non-accidental if you're not getting them referred in the first place into the Safeguarding Adult team. So we've worked with primary care and other providers within health to upskill them to recognise what may potentially be a non-accidental injury in adults. And then we have worked with social workers so that when they're triaging in the SAT or the assessing teams who go out to the care homes, that they also can recognise non-accidental injuries. So we've done as much education as we can. We've been really lucky because lots of people have given us their time for free. So that's been really good, and as I say, has been really helpful. And the other reason, the other thing that I'm doing is I'm doing a doctorate at Teesside University looking at injuries in adults at risk of harm. So I was in Teesside yesterday trying to get myself organised. So this is the workshop which I've told you about. I think what I didn't say is we do the court session as well, because I think everybody, when they start this work, their biggest nightmare is the thought of having to go to court, and I can sympathise with that, because I've been twice now, and no matter how well prepared you are, it's always a bit of an unpleasant experience, really. And the police deliver a session on how we can work best with the police to get the best outcomes. I think the police are probably our slowest partner to come really to the project. I mean, they come, but they don't always do what you think that they should do, but there we go. So as I say, that's our course, and we've run it about 3 or 4 times now, and it's been good. And each time we've run the course, we've looked at the feedback and we've tried to improve it. So one of the things that we've added in recently is, because one of the difficulties is communication with adults at risk of harm. They may have a profound learning disability, they may have neurodiversity, the vast majority of people have dementia. So it's about communication, and so we had a fantastic psychiatrist last time who specialises in dementia and communicating with patients with dementia, who delivered a session about how you might work out how you can justify what a person's told you, because something that I always do when I go to do a visit is I write down what the person tells me, even if at the time it seems a bit outlandish, because quite often when you get home and you look at what you've written, you can see where they were coming from, and they quite often either have told you or give you clues as to what's actually happened to them. So the FFLM now have Safeguarding Adults on their website, which is really good, and they have some really useful resources on there. And that is just freely accessible to any member of the public, so anybody can access that. We have a quarterly peer support group, and that really anybody can come to that who is working in adult social care. So we have a smattering of healthcare professionals working in adult safeguarding. We have specialist forensic physicians who come, who may work in sort of SARC settings particularly, because they're interested in the adult safeguarding, because they see clients with learning disabilities and dementia. And it's a really good peer support group, and you can book. We limit it to But we limit it to 30 bookings, and we usually then have about 22 people come. And the whole idea is it's a safe clinical space to discuss cases confidentially or anything else in terms of any aspect of this work. And it is really good. So I co-chair it along with Margaret Stark, because she's got the really good forensic expertise, and I would hope that my grounding in sort of health aspects of safeguarding adults is reasonable. So we co-chair it together, and it's always a really good group. We have some regulars who come really every time, and then we have people who drop in when obviously they've got something difficult that they want to talk about. So it's really good, and I would recommend it if you wanted to come, then just book on. You just go onto the website, find the adult safeguarding page, which is tabbed, and then go from there. And they have other resources as well, which is really helpful for adult safeguarding. So how does the service work? So we had our initial focus group about, how on earth are we going to do this? And then once we'd got some education up and running, it was like, this is getting a bit scary. We now need to start running a service, really. So we had another series of, it had to be online because this was all in COVID, so it was a bit tricky at times trying to develop a service during COVID, but we our board supported us, and we had breakout groups, and people rotated around these breakout groups, and there was a breakout group about what do we need in a policy, what do we need in terms of ongoing education. Practically, how is this going to work was one of the groups, and also how are we going to evaluate it. So electronically we were all put around our Teams rooms, and from what was said at that meeting, we wrote our policy. Initially I wrote it with one of the board managers, somebody from the Acute Trust, and one of the Safeguarding Adult Team social workers. So it was written by a fairly tight-knit group of people to start with, and then it went round all our partners for review. So this is how the service actually works on a day-to-day basis. So an alert will come into the Safeguarding Adult Team just in the normal way, and we've been working really hard to get people to highlight if there's an injury or if there's physical abuse. So when the social worker triages that, if they think that this injury may be as a result of physical abuse, and we've got some guidelines that are on East Riding Safeguarding Adults Board website about what may be a non-accidental injury, and they will then communicate with me. Now that's normally email, because that's probably the most reliable way of communicating with me. So they'll communicate with me, and we'll have a discussion as to whether or not this may be a non-accidental injury. And quite often by this stage we've got photographs, which is really handy in terms of triaging those calls. And if we agree, and we usually do agree, then we will arrange to go and do a visit. And then I always go out with a social worker. It's in the policy that it's a joint visit. So I will go out with the social worker, and then we each have our sort of prescribed jobs that we do when we get to wherever the adult is. And as I say, I'm happy to share these slides, and these links will take you to the policy on East Riding Safeguarding Adult Board website if you wanted to have a look at it at all. And then on the day with the social worker, we will, we've even sat in the car in the rain, which I'm sure you're all used to doing, if we've got nowhere private to talk. When we finish what we've got to do, we'll have a private discussion just between the two of us at the time to say, what do you think? Because I don't want to go down a rabbit hole. I always want to talk through it with the social worker, listen to their views on what they've found. I will say what I think and what I've found, and then obviously there'll be a sort of interim decision about any immediate safety plans that needed, but then we do have a strat afterwards, but we do have that initial discussion. So consent, obviously it may be the person is able to give consent, but obviously if they can't, then we will need to use the Mental Capacity Act. So what normally will happen is when we first arrive, wherever we're going to arrive, I will go and see the person sometimes on my own if I'm going to do the capacity assessment. I prefer to go with somebody who knows the person well, but it doesn't always work out like that because it depends on all sorts of different things. So really it's, can the person understand the need for a forensic medical? Because obviously examining somebody without consent is an assault. So, can they understand? And then if they lack capacity, after I've done that capacity assessment, I'll come back to the social worker and we'll have that discussion about our best interests. If there's carers there, which there usually is, we will ask them what they think, and then I will quite often phone a relative if that's possible. I mean, I always try and phone a relative. Sometimes the social worker's done it before we go, and they've said, so how would you feel? So, but I normally would phone a relative or somebody close to that person. So that's sort of the process we do in terms of seeking consent. And these are the kind of things that I tell people when I'm doing the capacity assessment. It might be uncomfortable because I need to look at people and sometimes keeping in a position while I do a quick sort of either photograph or drawing or whatever I choose to do, so it might be uncomfortable. They've got to be really aware. It's not like going to the doctor, who may look at your sore throat, because on the whole, if the doctor looks at your sore throat, then he's not going to share that information with anybody else. But really, whatever I find, I am going to share, certainly with adult social care, and then it gets shared with the police as well. So it's not just about, I'm going to feel your tummy, it's about, who am I going to share that information with? And then, people have to be realistic that as a result of that examination, it may be that the carers get changed, the place of care gets changed. So there's all these considerations. So it's not just about saying, open your mouth and let me have a look at your throat. It's a bit more complex than that, really. And people do need to know that there is a possibility that this could lead to some sort of, either criminal prosecution or, somebody's DBS being marked. So there are consequences of having a forensic medical. So in terms of supported decision making, we have a patient information leaflet. Again, we had fantastic support from both our boards in North Links and East Riding, and they so I wrote what I thought was quite person-centred, leaflet, and anyway it was sent to the read-write group of Health Watch, who sort of fell about laughing and sort of rewrote it for us, which was great. So we have a patient information leaflet that's been through 2 read-write groups, and we also have an easy read leaflet which one of our board technicians did for us as well. So I always take those with me. In all fairness, most of the people I see aren't able to read the written leaflet, but then I do give it to whoever I'm making that best interest decision with. So it'll go to mostly a relative, and I also give it to the care homes if they want to have a look at it too, and then we may, as I say, use the easy read leaflet. And I use the easy read leaflet not just with people with dementia. I may use it with people not just people with a learning disability. I do give it to people with dementia because sometimes that they can absorb the pictures even if they can't absorb the words. So we have tried our best in terms of supported decision making. So these are figures from our first year, and as you can see, the vast majority lacked the capacity to consent, so that means we go through the best interest. 4 had capacity and consented, 2 had capacity and actually refused to be examined, and I'll talk about one of those cases a bit further along, but I am absolutely sure in both of those cases there was an element of coercion and control and fear about what might come as a result of the examination, that somebody who was close to them, probably who they were frightened of, may be implicated, and they're quite difficult. I think they're quite difficult for everybody. I know the social worker I did one of the visits with that I'm going to talk to you about was really upset by the fact that this gentleman wouldn't let me examine him, and I was equally upset. So I'm always accompanied when I do the examination, and really I just try and take with me, obviously not the person who may be the perpetrator, but really somebody who knows the person really well. And for instance, I did a care home visit a couple of weeks ago, and they'd arranged for what was the senior carer to come with me. But it was patent, and this lady had dementia. She wasn't too keen on me being there. And it was patently obvious that actually one of the young carers knew this lady really well. And so in fact, the young carer, who was quite junior, came and took over. So really for me, it's just about who knows the person best and who can help me communicate, because really all the patients have some sort of difficulty in communicating or understanding. So that's really important to me. Really important to maintain dignity at all times. And I try, you know, in a perfect world, I would look at every bit of everybody to make sure they've got no injuries anywhere else. But sometimes, you know, especially if somebody's a bit upset and you think you've probably seen enough, you have to accept that you're going to do it as quickly as possible, and maybe not see absolutely everything if it's going to really upset somebody, and really just work with the victim to try and you know, keep them as comfortable as you can at all times. So referrals by age, so this is who we've seen. This is, I think the numbers are irrelevant really, it's just the shape of the graph, and it actually, if you look at the figures for the section 42s for the whole of England, that just mirrors, it basically shows that the older you are, the more at risk you are of physical abuse. And again, that goes with those academic studies we've seen that show the frailer you are, the more long-term conditions you've got, the more likely you are to be the victim of physical abuse. So I think in a way that graph pleases me, just in the sense that I think we must be seeing, you know, the right spread of people really. So down on the left you'll have people with learning disabilities, and then obviously up on the right you'll have the frail elderly as you sort of get older. So injury by type, what do we see? I mean, we mainly see bruising, and that's slightly problematic in the sense that identifying the cause of a bruise can be really difficult. We have to go on where the bruising is on the body, whether there's any sort of imprints, and I have seen imprints of things on people. I've seen the imprint of a shower mat on somebody's shoulder. So, you know, we can usually come to a reasonable idea of whether we think this was non-accidental or not always. We've seen, when I say we've seen fractures, I've been asked advice about how this fracture could have happened. So obviously it's a bit like the non-mobile baby. If you've got somebody who is end of life, we've had fractures in people who've been end of life who theoretically never moved from their bed. Well, you know that must have, you know, something must have happened that shouldn't have happened. So you just have to find out what you can, and if necessary, because I'm not an expert on fractures, although my knowledge is increasing, you know, phone a friend. And I've been really lucky in that, you know, if I ring any of our consultants at the trust and say, oh, can you tell me about this? What's the possible mechanism? I've never had anybody who's not wanted to talk to me. So abrasions are basically scratches. We've had a couple of burns. And that's been really interesting, because we had one burn in one lady, and where she was cared for, they were adamant it wasn't a burn, but the ACP, the GP and me all said it was a burn, and I spent ages actually looking to see whether this blistered thing could be anything other than a burn, and it was obvious it wasn't. But you do get kickback sometimes, which is quite interesting to deal with. Laceration basically means like a skin tear, and then we don't deal with sexual assaults. But what we have found is we've had, I think now we're up to five women and one man who've come into the service with injuries, and then when we've looked at those injuries, they are, you know, it's either bruising on the breasts, and it's really hard to bruise your breasts. It's really unusual to see a bruise on a breast, along with bruises on the inner thighs, and then we've, you know, realised that this has been a sexual assault, and we've done some really good work around working with our SARC and working with our police to make sure that those SARC medicals get done in a timely manner, because the biggest problem with SARC medicals is that they need to be done in 7 days if you're going to get any forensic evidence. And so, you know, if the referral comes in on a Friday night, it's bank holiday Monday, you know, you've really only got sort of 2 or 3 days left to do it, so you've got to work in a really timely manner. And as we know, getting the police to work in a timely manner sometimes can be tricky. And the other thing is, certainly in our area, and it seems to be fairly widespread, that some of the SARCs, you can self-refer to a SARC, and this is another discriminatory thing. So, if I were sexually assaulted, I could just ring up the SARC and go and be seen. If you've got a learning disability and don't have the capacity to self-refer, the SARCs quite often won't accept that referral apart from the police. So you need to get the police on board as quickly as possible. I think it sometimes depends who your SARC provider is, but certainly in our area it's caused a lot of problems. And again, we've done some upskilling of people to realise how this needs to be done in a really timely manner. So, as I say, we don't see sexual assaults, but we do. Although we now have better relations with our SARC, and I mean, as you know, they will come out to care homes, they will come out to see people with learning disabilities where they're being cared for, but it does need, it's like I call it the chest pain of safeguarding sexual assaults, in the sense that with chest pain you'd dial 999 and send somebody into hospital, and I think sexual assaults coming through the site, you should have that same sort of urgency. No, we need a strat today, and it's just not understanding about that forensic evidence, really. So I was just going to talk through a couple of 3 cases I think I've got, and I apologise because I've got a duplicate slide which I only realised last night, but we'll just skip over it when we come. So this was an elderly lady. She was really frail. She was a care home resident. She was in one of our specialist care homes. She was a really severe fall risk, and so she had one-to-one care 24 hours a day. So what happened during the day was that the care home regular staff fulfilled that role, but overnight there was a well-known agency, an agency that the care home used all the time, and it was actually mostly the same worker who came in and was with this lady. So it was a well-known agency worker. It wasn't somebody who just popped up that day, who was looking after this lady on this particular night. And she had really significant bruising to one side of her face around her eye, and a sort of facial injury. I mean, it was so severe that the GP actually saw her very first thing the next morning and sent her into hospital. I mean, they'd sent her back by lunchtime, saying that, although it looked awful, there was nothing sort of really significant. So I worked with the manager, and as I say, this was a really, really cracking care home. It was great. And we established a timeline, along with a social worker. We established a timeline for every single thing that had happened to that lady through the course of that 12 hours. We basically looked at the 12 hours prior to the injury being found when the day staff came on, I think at 8 o'clock in the morning. She had some amazing technology, which I'd never seen before, so that was a really good learning experience for me. I'm sure you've seen it. So she had the technology basically within her room that could really track her movements. So she had some special mattress that when she tried to get up off the mattress, it alarmed. She had the mat on the floor. So the technology could track her movements, really. That showed that she'd never really left the bed. So that was, interesting. So there was the staff who were permanent staff at the home. They could give a history of the night's events, the care episodes, because most of the time she had one-to-one care, but obviously if she needed any sort of personal hygiene dealing with, then another member of staff would come in and help with that. And as I say, the technology showed she'd not left her bed. So the 2-to-1 care, so that was the permanent member of staff. They'd done some personal care. This lady had difficulty sleeping, which is really common in dementia. And so when the permanent member of staff had left the room, she was sitting on the edge of the bed with one of those tables in front of her, with a bowl of cereal and her colouring book, which is, how she liked to be. So that was the sort of evidence that we were, had collected. I mean, it was obviously a bit more in depth than that, but that's basically the outline of what we did. So when you do forensic medicine, I think when people started working with this project, they actually found it really difficult. You have to think of every single scenario that could have caused that injury. So when you say to somebody, well, of course somebody could have given her a right hook, they look at you and say, oh, terrible thing to say. But you just have to think of, could she have had a fall? Could somebody have hit her? And, could she have, nose-dived into her cereal bowl? Could the technology have failed? So we had to look at every single scenario. And when I write a report, I put every single scenario into my report in the discussion bit. So option one, fell asleep and fell forward onto the table and hit her head. That probably meant that the carer had probably nodded off, in the armchair opposite. Could have been assaulted. So we looked, it's a specially built care home, this. We looked at whether there was any evidence for any resident on residence, so was there any wanderers, had anybody been in the corridors causing any difficulties or very upset, and there was no evidence for that, and technology backed that up because you can see when doors have opened and closed and things. Could the technology have failed and could she have fallen to the floor? Well, they could show me like the printout that everything was connected, so that seemed really unlikely. So discussed with the manager and we agreed that there was no evidence for any technology failure. In terms of the lady herself, she had she had no behaviours that challenged, because those are the people who quite often may get assaulted. There's lots of evidence that if you've got behaviour that challenges, you are much more likely to be assaulted by another resident or a member of staff. And the agency worker was long-term, never any problems. So we thought that was really unlikely. And so we really sort of came to the conclusion that she had literally just fallen forward onto a hard hospital-style table with a cereal bowl on it. And the injury would fit with that. So I wrote this report and I sent it to the manager. I'd told her what I was going to put on it and sent it to the manager, and I said, would she share it with the family? Because I think families, when you've got a relative who can't tell you what's happened to them, families want to know, they want to have some idea of what had happened. And the manager said, I don't fancy telling them that, we've looked at whether she could be assaulted or not. And I said, well, don't you think that's important, that we've looked at it and really felt that it's not likely? Anyway, so she shared this report with the family, and they were actually really pleased that we'd set it out in possibilities and then justified why we'd gone for the option we've gone for. So I think it's really important for families. And one of the bits of research I'm doing for my doctorate is about looking at SARS for physical abuse. And, there is some evidence in there that families do feel cheated, a bit like adult A's family when somebody's had injuries and they haven't really been, nobody's really given them a possible explanation. And I think most people are willing to accept that we'll never completely know, but I think they like to know that we've actually thought of all the possibilities. So obviously my responsibility is to write a report. I go to the Strat afterwards with the police and adult social care, and then I will make recommendations for safety planning, because I think that's right. So, obviously a lot of it is around falls, manual handling. Obviously I work with a social worker on those, and rarely, and I can only think of 2 or 3 cases in the sort of 2 years we've been running, I've recommended that somebody's moved. So we had a lady who was almost certainly a victim of non-fatal strangulation, and I said she can't stay where she is because that, takes 6 minutes, I think, to strangle somebody. So, those are the kind of recommendations that I will make. Now this, I'm afraid, So, this was a really interesting one, and this really got my Clouseau sort of head on, really. Mainly because I was, something got up my nose. So this, again, was an elderly, frail care home resident. She was admitted to hospital with a fractured shaft of femur. Now, we all know that old people fall over and fracture their neck of femur, but the shaft of your femur is the long bit, basically, which is really unusual. It's a really unusual fracture, apart from in a road traffic accident. So, it was quite an unusual fracture. And she alleged that a carer had pulled her out of bed by her feet. So this is what she said. I know. I mean, you couldn't believe it, really. And so nobody did believe it. So the care home said, oh, she's confused. And the son, I mean, this was really interesting, peculiar dynamic. The son said, the carer would never do that. I know them. They're a really nice person. So we were left with this lady with this fractured shaft of femur, which was a significant injury, really significant injury, who alleged that somebody had pulled her out of bed by her feet. A care home that's saying she's confused, and a son who, you know, is saying the carer's lovely. You know, he'd never do that. And so the care home was known to have some difficulties, and I won't go into them because there's a SAR about them that's still being written, and there's caused a bit of controversy. For me, because I knew about the other stuff that had gone in the care home, that carer's name had popped up already. And so for me, that was like, ooh, you know, what's going on here? We've already heard that carer's name from something else to do with this other incident. So here he is, bizarre, popping up again. So, you know, I thought we need to maybe look into this a bit more. We need to look into it anyway. So what did I add and what did I do? I didn't know about fractured shaft of femurs, so I rang up the consultant that she was under just to ask what he thought really, and it was really interesting because it was actually a bit of a spiral fracture, which means it went round in a bit of a curvy circle really, and so I said to him, oh, you know, can you just tell me anything about a fracture? And he said, well, it's really unusual. Oh, okay, says I, and I don't let on anything else. And he says, well, it's probably been caused by a twisting injury. And if you think about it, if you pull somebody out of bed by the feet, you probably are going to twist them, because if the bed's got a footboard on, then you are probably going to twist them. So we then have an orthopaedic surgeon saying this is actually a really unusual fracture, and the mechanism was probably a twisting type movement. So that sort of backed up what the lady was saying. So I then accessed, so through System 1 I could access her medical records. So I went into her medical record and retrieved a letter from the memory clinic, which had only been written about, I think it was less than 2 months prior to this incident. So this lady had had some really significant cognitive impairment, but it had been associated with really severe anxiety and depression. So she had had this significant cognitive impairment. She'd been referred to the mental health team, but as her anxiety and depression improved, her cognitive functioning had obviously improved with it. And I mean, we know if you're going to do your driving test, you can't think of anything, can you? And you know, this was the same for this lady. And so the mental health nurse had written a really good letter, and she said she performed much better on testing this time. She knew who I was. She gave a good account of herself. She was orientated in time, place and person. So I could go back to the strategy meeting and say, actually, everybody says she's confused, but the evidence from the memory clinic is that actually she's not as confused as everybody thinks she is. And she may have been confused in the past, but actually for her, things have really improved. So the two bits of information that I could contribute to the stat were it was an unusual mechanism, you know, it possibly had been caused by some sort of twisting injury, and that the lady should be believed. You know, that if this is what she says has happened, then looking at the injury, looking at the mental health records from the clinic, I think we need to really, you know, believe her. So, yeah, I've done that. Yeah, so this was substantiated that the carer had probably done this. So they were dismissed, the DBS was marked, and that did go, he did get prosecuted. So, you know, it was really valuable for us all to work together, use everybody's bits of skills and knowledge, you know, the memory clinic nurse, the orthopaedic surgeon, me helping pull it together. And so that was really good. So I think this is the last one, in case you're all beginning to wilt now. This was one of the less good outcomes for me. So this was a man in his mid-40s. He'd got a learning disability. He lived in his own little sort of bedsit flat and I call it a supervised block because it is, this was specially built by East Riding Council, and it's a block that has the same, the council's care staff go in on a daily basis. It's got nice communal areas, and the care staff are very embedded in, being the eyes and ears of the place. So it's a really lovely, well-managed, well-run block with a steady group of carers. So it's not as if there's agency carers from different agencies going in. So he lived alone. His sister and brother-in-law lived round the corner, and they provided support, and I put that in inverted commas. Now, we knew the brother-in-law, he'd actually been in prison for domestic violence. So we knew, and it was relatively recently, so we knew that he had got a propensity for being violent. The support staff put in an alert and said that it was a really hot summer, it was June, extensive bruising to his anterior chest. So this was really, it was a good referral, it was a prompt referral, and we knew he was known to adult social care, and we knew that there had been issues previously. And I mean, to go to prison for domestic violence is actually relatively unusual, so it must have been pretty horrid. So what do we know about bruising? Because I said already that bruising is really tricky, and I hear all the time, they're on an anticoagulant, they bruise really easily, they're old, all these sorts of things, and so it is really difficult. So this again is an American paper, because nearly all the papers are American, and this was looking at bruising in people who've been physically abused, and so what it's saying is that bruising, so if you've got a whole sort of a group of controls who haven't been physically abused and a group of people who have been physically abused. Bruising is much more common in victims of physically abuse. What we do know, again, and I think if this is the one thing you take home from today, head, neck and torso, so head, neck and torso is really from your shoulders to your bottom. If you've got bruising there, that should raise your antennae, because that is much, much more likely to be as a result of physical abuse. Falling, you get bruising on your extremities, so that's why the control group, which is the group in brackets, people who fall very commonly have bruising on the lower legs, and quite often on your wrists and stuff where you put your wrists out, whereas people who've been physically abused tend to have less bruising there. And then this paper says, and I'm not sure, I've never seen it in another paper, that the bigger the bruise, the more likely it is that it's physical abuse. Don't know about that. I've not seen it in another paper, but she felt, this lady who did this, felt that was common. So he had capacity, and he declined the examination. So what had happened was the social worker had rung him the day before and said that her and myself were going to go and visit him, and was that all right? And he said, yes, that's absolutely fine, I'll be there. And we arranged a time and we went round. And then by the time we got there, we did just about get through the door, he got really agitated and really quite aggressive, and basically asked us to leave the flat. And we think that what had happened was, in the interim between us ringing and saying we're going and us getting there, that he'd spoken to his brother-in-law and sister, and they'd told him not to let us in, because I then subsequently spoke to the GP about this, and he said, oh, that's really unusual, he's normally really, really easygoing, and I've never had a problem getting in. And the social worker was already onto it in terms of some financial abuse that had been an ongoing long-term thing, in terms of the family probably taking money from him, basically. So just to go back to him, because it was June, because he didn't have his T-shirt on, I actually saw the bruising while he was basically telling us, to go away. And I am sure he had been thumped. It couldn't have been caused by anything else. It was sort of fist-shaped bruising mostly on his anterior chest wall. And so even though I didn't examine him, I could contribute and say, I don't think there's any way, because he said that something had fallen out the fridge. Now, you're not going to get a bruise from a bottle of Coke falling out the fridge. So that was really difficult, and I think that's one of the cases that, it's really hard to make a difference when somebody won't let you in, they've got capacity. The only thing that did come from that was that I think the council applied for deputyship to manage his finances, so that did change things. But it was, and I told the GP, so everybody's aware about this man being at risk, and you know, it's a case of sitting and watching and waiting really, which isn't, you know, it's holding that risk. So the first year of the project was evaluated. The evaluation's available online. It was done independently by two social workers from the University of Hull, David Marsland and Caroline White, who've done similar evaluations for safeguarding issues previously. And that was basically positive, which was really good. You know, the social workers felt it was beneficial. The people within health felt it was beneficial. The police wouldn't be interviewed, so we don't know what the police think. But there we go. That's, as I say, we're working on them. We're into phase 2 of the project now. As I say, we've got funding for a second evaluation, which is going on at the moment. And the business case has actually been written, and it's going to be rolled out to the ICB. And so we've done a train the trainer package for physical abuse for, we call it level 3, because we have, well, we've got new guidelines, haven't we? We've got the RCGP guidelines now. And so this is for level 3, and the idea of this, and we've worked on this with Newcastle and Gateshead, with Karen Hutchinson, who's the named doctor in, yeah, she's Newcastle and Gateshead, isn't she? And her and I have worked on this, and what we've done is we've written a level 3 training package all around physical abuse. It's been recorded. It has actually now been recorded. We've recorded it twice for various reasons. We've written some notes, so there's quite extensive notes with each slide, and the idea is that people who are, well, the idea is really that named doctors around the country can use this to they can watch the video, they can have the set of slides, they've got the notes, and then they can present it in their areas. And that's to raise awareness about physical abuse, because, as I say, I don't think there is that much training really. So we did that. We did that in collaboration with the Faculty of Forensic and Legal Medicine. So they sort of quality controlled it for us. Karen and I presented it, and it's going to be disseminated nationally soon, and it's going to be available again on the Faculty of Forensic and Legal Medicine website, because if we put it on there, it's, you know, anybody can access it, so it's really handy. It doesn't, you know, you don't have to go through any horrible, you know, whatever to be able to get it. So that's me done, you'll be pleased to know. So thank you very much for listening and for inviting me in the first place. So thank you.